which I'm a part of. So I would like to share some of the results, especially through the social media platform that we've had through psychoeducation posters, which are evidence-based content. So our reach has been 55,744 through 73 posts. Number of followers is 1,220. And we have innovative content such as Mukti by Art, so sober and stylish, movement, and also Mukti for exam stress. Proposed and ongoing research projects is to make the model of Mukti self-sustainable and replicable nationwide, to analyze the effectiveness of the training session for medical students in motivational interviewing, to analyze qualitatively via interviews the effect of helpline run by medical students in knowledge, attitude, and practices of people using substances, to analyze quantitatively the effectiveness of a helpline run by medical students to decrease their substance use, and adequate support of relatives suffering from the substances, to evaluate the prevalence of substance use in students of Mumbai University. However, some of these are ongoing and some of them are yet to get approval. Results of the helpline, which has been the most important thing of Mukti, which is very unique to Mukti. Impact of the helpline. So in the qualitative study, we had a modest number of 5 people that we first started with, and in which we assessed aspects of behavioral pattern, insights into substance use, improvement in interpersonal relation, and improvement in professional career, knowledge, and encouragements to quit others. So following are the numbers. As you can see, 5 out of 5 had aspects of improvement in behavior pattern, 5 out of 5 in insights into substance use. And only professional improvement was noted in 2 out of 5. So the quantitative aspect, where we assessed the quantitatively number of people, and also this is to bring to your notice that all the material that I'm put forth right now is 6 months down the line we started the initiative. So we are almost 2 years today, but we still have to speak to our counselors and get the data. So we are only presenting data that is 6 months down the line. It was conducted from the study a telephonic helpline, and in which what we found out, 16 were tobacco users, 3 were alcohol users. Out of the 6 tobacco users, 6 were able to quit it completely at the end of 6 months, and 3 people were able to reduce its use, while 7 were unable to do it. While out of the 3 alcohol users, all 3 were able to reduce the consumption. So another important aspect of Mukti is our volunteers. We have over 120 volunteers, and we keep adding new volunteers every year through a recruitment process. And we also noticed that our volunteer impact has been very important. So we also noticed that itself being part of a motivational program motivates them to decrease or contemplates them to reduce their substance use, and they have gained skills like leadership, empathy, communication, time management, medical research, and networking. We are the study where we are assessing the training impact, where psychiatrists are giving training to medical students, in which the WASAR tool is a validated tool developed in the US actually to assess a brief intervention, and in which we used it, and it was only on 15 participants, control and the study group, in which we found a significant difference in the scores among the ones who had undergone the training program versus the control group. So thank you, and I would like to thank all our the Mukti team and our mentors, and our social media handles are Instagram and Facebook is Mukti, and also Powerful Gyan, which is another aspect by one of our mentors. Thank you.
Thank you, Shilpa, for the presentation. We will go on to the next panelist, but just I would like to encourage everyone who's attending to please leave in questions for Shilpa, and we'll take that at the end of the 3 opening remarks from each of the panelists. So we'll go on to Atul now. Dr. Atul Ambekar is an addiction psychiatrist working as a professor at the National Drug Dependence Treatment Center at AIIMS in New Delhi. He divides his time between clinical care, teaching, training, research, and public health program activities. He's a passionate advocate of evidence-based alcohol and drug policies and programs, and has been providing his expertise to many national and international agencies, including the WHO and the UNODC. The epidemiology of substance use is a research area that is close to his heart, and he has recently concluded the largest national survey on drug and alcohol use in India. Dr. Atul, I welcome you now.
Thank you, Urvita. Thank you, Sangath, for making me a part of this very interesting webinar. I'm pleased to be here in the august company of two very esteemed speakers. I was very encouraged to hear about MUKTI from Shilpa. I don't have a set of slides today. What I'm going to do is I will just talk about some of our research experience in the area of epidemiology. Since I thought we are supposed to talk mainly about innovations in addiction research, so I thought I think I should give this opportunity that to discuss the kind of epidemiological research which has been taking place in India, particularly those which in which I have been a part of. Now, begin with, as far as substance use epidemiology is concerned, the question is why is it important? The first and foremost is the field, particularly both the mental health and substance use. They are highly stigmatized areas. They're highly stigmatized areas. They are something which are problems which are faced by a large section of the society, but their their true impact, their true burden is always either minimized or it is overestimated. Either people tend to minimize the burden of mental health or substance use in the country or in the society, in the community, or they have the kind of explanations or assertions like, oh, almost everyone is doing it. Majority of students are into smoking and taking drugs. You will often hear these kind of statements being made by people. So in order to have, or even by politicians, right? Politicians once famously said that 70% of Punjab youth are addicted. And in fact, that's what prompted us to do one study in Punjab, and I'm coming to that. So basically, it's very important to actually measure, assess, and document what exactly is the burden that we are talking about. What is the size of this beast? So that's why epidemiology becomes very important. So, but then the one aspect is just telling you the numbers, that X percentage in this city, in this country, in this state, or within the student community, within the driver community, X percentage are substance users. This is just one piece of very important, but this is just one piece of data. Another important issue is the going into the depth about the actual consumption pattern, actual behaviors, and actual consequences of substance use among those who are using substances. So, for instance, it's one thing to talk about how many people who inject drugs are there in Punjab or in Manipur. But within those people who inject drugs, how many of them are sharing their needles and syringes? How many of them have experienced overdose? So some of the detailed behavior parameters and the epidemiological approaches for answering both these kinds of questions are actually different. So I'm just going to give a very brief overview of what kind of approaches we have used for either of these as well, and the kind of challenges which we have encountered and what the solutions we have found. And finally, I'll very briefly talk about the importance of sharing the results of of your epidemiological research at the right kind of fora. So to begin with, the numbers game. How many people actually use drugs or substances in a particular area? So I'll just talk about one of the very old studies that we conducted in Punjab, Haryana, Chandigarh in 2007. And this was the time when the entire country's focus as far as injecting drug use and HIV is concerned was largely upon the northeastern states. There was raging HIV epidemic among people who inject drugs in Manipur, Nagaland, Mizoram, and Meghalaya. So everyone thought that this is actually the area where injecting takes place, and other parts of the country were largely not on the injecting HIV map or the radar. But Punjab actually started showing some signs in the early 2000s itself of increasing injecting drug use and the associated problems in Punjab. But no one was actually willing to take it seriously. So that's why we, along with civil society, an NGO called SPYM, we approached some stakeholders, including some government agencies and United Nations agencies, and together planned a research study on size estimation of injecting drug use in Punjab, Haryana, Chandigarh. Now, again, for size estimation or for determining the numbers that I was talking about, a very common approach, if you talk to anyone, is that how will you estimate how many people are there who take alcohol or drugs in a given area? They will say, oh, let's do a survey, house to house survey. Fine, that can be done, but then it will be very intensive. Okay, then if you can't go to every household, just take a sample. You don't need, if there are 1,000 houses, you don't need to go to everyone. Just take a sample of 50 houses and find out how many people use alcohol in those houses. Fine, this is also something can be done. But the problem here is there are some unique challenges to conducting household surveys for socially undesirable and stigmatized behaviors like substance use. So if you, and within substance use also, there are degrees to which a particular kind of behavior is acceptable and particular kind of behavior is not acceptable. So if someone comes to my house and asks me, do I drink coffee? I will say readily, yes. Aapke liye bhi banau kya? Right? If they come and ask me, do you drink alcohol? Perhaps I might still be willing to say, yes, okay, I don't mind taking a drink or two occasionally. But if they ask me, do I use cocaine or do I inject drugs? Then I may perhaps not be so forthcoming in sharing this kind of this kind of information. So hidden phenomena like injecting drug use or many of the risky sexual behaviors, these are those kind of behaviors which are regarded as socially deviant, stigmatizing, and hence general household surveys are not able to pick them up. On the other hand, people who use drugs or people who engage in many such behaviors, they know each other. They have a network with each other. So if we call them hidden phenomena, they are hidden from the general eyes of society. They are not hidden really from each other. Using psychoactive substances is very often a group activity, or even procuring them from the underground market becomes a kind of gray market, a gray network of individuals like this. So approaches, epidemiological approaches which are based upon social network principles, they are more appropriate for reaching out to this kind of population. And that's what we employed in Punjab, a technique known as RDS, respondent driven sampling. What this technique is simply uses the social network of people who inject drugs. You initially identify and spot some people who are of interest to you. You talk to them, and then you give them this task that please go out, find other people like you, and send them to us for further interview, further discussion. So let's say there is, I find one person who inject drug in Ludhiana, and I ask him to get more people who inject drugs like them from Ludhiana. They might know 50, they might know 100, they might know 75, and all of them may turn up at my door. So that would again be a problem. So to circumvent this problem, in this approach, RDS, respondent driven sampling, we put a cap on number of people they can refer to, number of respondents they can refer to. So in our case, we put a cap of 3 people. Okay, yeah, whatever the number of people you know, just send 3 people to us. So when those 3 come to us, we interview them, then we ask them also to go out again and send 3 more people to us. In this manner, we go on and reaching out into the depths of network of people who inject drugs until the desired sample size is reached. And that's where an equilibrium is supposed to have reached. All the detailed information which is collected from these individuals undergoes statistical analysis, and that analysis actually takes into account who referred whom, who was in contact with whom. how many males were referred by females, so or how many out of towners were referred by people who belong to this town. So on different socio demographic and drug use parameters, the software, the statistical program, it takes into account these variables and gives us weighted prevalences. Now it's a statistical term. We will not go into too much depth of it, but basically, if the software tells us that 14% of injecting drug users in Ludhiana inject heroin, so that means 14% of all injecting drug users in that area, the population of injecting drug users in that area injects heroin. So the statistics which we get, the prevalences which we get from a respondent driven sampling sample applies to the population, that particular population in that area. And there are some other statistical technique through which you can actually estimate the size of how many people like this are there. And this is the approach we successfully first used in Punjab and Haryana in 2007 and documented a very large number of people who inject drugs, which further then resulted mm, in rolling off the programs on specific harm reduction programs like needle syringe exchange program and opioid substitution treatment for people who inject drugs in Punjab, Haryana, and Chandigarh, and sort of actually made this evident how serious this problem in Punjab, Haryana, and Chandigarh. So what are the research methodology type of lessons here? One take home point for us is that number one, household survey approach, which seems the straightforward approach for any other epidemiological study, is not very suitable for socially deviant behaviors, particularly the rare and illegal drugs. That's the lesson we learned. And secondly, these network-based approaches can be very successfully employed in Indian population. Mind it, this was still very early days, and so far till that point in time, this approach had never been used for injecting drug users in India. So this was something later on was accepted by the government also as a type of approach which can be utilized. And subsequently, we took this work of injecting drug use forward and tried to document the variations in injecting practices across the country. So for that, we just took small samples of around 100 injecting drug users in 22 cities of India each. And those 100, we, through network approaches, we approached them, got detailed information of them. This was again a United Nations supported study available online. And in this study, we actually described that the phenomena of injecting drug use is not uniform across the country. So people do not inject the same type of drugs everywhere. People do not also even use the same size of syringes everywhere. So what are the implications of this kind of work? This actually demonstrated the need to tailor the intervention programs as per the needs of the local population after conducting a needs assessment. Otherwise, since this was mainly meant for the National AIDS Control Program. Otherwise, in government programs, when the norms are established, then once Delhi says that everyone must get a 5 ml syringe in the entire country, everyone will get only that syringe, forgetting that some people inject 10 ml of drugs and some people inject only 1 ml. I just gave a very broad kind of examples, but such kind of nuances were important to bring out through epidemiological research, and which then fed into designing and overhauling the program. So another lesson learned from this is that that appreciating the finer nuances and diversities of the population that we are working with are important, and research can throw important lights on this. And quantitative research, I mean, I'm not talking just of qualitative research. Qualitative research has its own importance, its own valuable insights, particularly for operational reasons. But even quantitative research of this kind also can be valuable. Finally, I will just quickly summarize with some of the experiences that we gathered from the national survey, which we conducted in all states of India simultaneously, which was a huge logistic nightmare. But I'm not going into the findings of that those are available online and anyone can see them. But some of the operational research methodology type of lessons that we learned from them is that one single methodological approach is not appropriate for all kinds of substances. So in this national survey, the estimates of alcohol and bhang, which are legal and socially acceptable substances, have come from the household survey methodology, while the estimates for the illegal substances have come from the respondent driven sampling method, which we had applied earlier in Punjab. So one lesson for us is doing some pilot small sized research gives you the confidence, some experience and some learning, which can then be scaled up at a larger level. That was one lesson learned. Second lesson learned is that data collection for substance use is really a tricky phenomena. You can barge into anyone's home, ask them some questions about how many buffaloes they have in their house, or whether they have a refrigerator or not, or how much is the education of the head of the household. But the moment you ask about alcohol and drugs, they would like to actually conclude the interview there. So a very sensitive, non-judgmental, empathetic approach is required there. And the key is not to begin your data collection directly by asking about their substance use. Wade through, just travel through various other health and lifestyle related questions, in which one harmless, innocuous question pops us about substance use. If the answer to that question is yes, then of course the algorithm takes you to asking further questions. So this is one of the lessons which we learned from our pilot also during while conducting the household survey on drug use. We also learned a lesson about sending the data collection teams with mixed genders. It's essential that every time there is a knock on the door, people see a couple, a boy and a girl, a man and a woman coming to your house. That increases the confidence of the people responding to these questions, allowing the interview to happen considerably. Monitoring of the entire research process is very important in terms of quality checks and quality assurance. And there have been occasions and the information technology, fortunately, these days, including GPS locations, can help us tremendously in terms of ensuring that data is actually being collected and actually being collected in the manner in which it should. Finally, about the dissemination and sharing of these results. Till your results are ready, it's very important not to share with anyone, even the whiff of it. While our results were being prepared, we were being pressurized by government agencies, by the law enforcement agencies also. And it was very important to maintain that confidentiality. Uh, and when we share and disseminate, there is value which comes from getting your results published in peer-reviewed journals, of course. And we academicians in government job, we know that value. But more importantly, if we have to have some kind of policy and program change, then you need the reports which are simple, which are large sized, with a lot of photographs and pictures and illustrations, and which can be understood by the bureaucrats, policymakers. So that's why it's very important to hold your dissemination, the dissemination tools or the instruments, as well as the interactions with the right kind of stakeholders, with right kind of forums, so that they actually learn and understand what is behind these numbers, what are the take home lessons, and how do programs and policies of government need to react to these numbers. So we were fortunate that after the national survey, the government has actually initiated the National Action Plan on Drug Demand Reduction, and something which is called as Nasha Mukta Bharat Abhiyan in some districts or more vulnerable districts of India, which has taken some of the lessons and some of the recommendations which has come from this national survey. So this, in short, what I wanted to share about some of the innovations in the epidemiological research that we have been able to bring out in India. And I'll be very happy to discuss further during the Q&A session. Thank you very much, ladies and gentlemen.
Thank you, Atul. Thanks for that excellent presentation. Very much look forward to the discussion that we'll have soon after. We'll go on to the last panelist for today, Dr. Nishi Suryavanshi. Dr. Nishi is a medical anthropologist and deputy director of Johns Hopkins India Clinical Research Program in Pune. She is a member of the faculty at the Johns Hopkins Center for Clinical Global Health Education. She has more than 20 years of experience designing, implementing, and overseeing clinical and social behavioral research programs in HIV and TB. Her research interests include mental health issues, gender-based violence, alcohol reduction, medication adherence, and women's empowerment amongst people suffering from infectious diseases like TB and HIV. Dr. Nishi, over to you.
Yeah, thanks, Urvita, and thanks, Sangath, for giving me this opportunity. I'll just share my screen. Okay. So can you see my screen?
Yes.
Okay. So I would like to share some of research findings of a novel computer-based avatar-delivered alcohol reduction intervention, which is a feasibility, adaptability, and acceptability study we conducted among people living with HIV and TB in clinical settings. So to tell you briefly about the background and the context why this study was needed, as we know that India accounts for about a quarter of world's TB burden and ranked third globally in absolute HIV burden. Additionally, unhealthy alcohol use among people living with HIV and TB is associated with unfavorable treatment outcomes. And Indian TB HIV programs actually mandate alcohol assessment before they start the patients on HIV and TB treatment, but there is no evidence-based alcohol reduction intervention that are provided through the program in the clinical settings to people living with HIV and TB. So we know that the screening and brief interventions based on cognitive behavior and motivational interviewing techniques are useful in detecting and treating unhealthy alcohol use in several settings. There are many studies which have shown that. But despite demonstrated efficacy, there are several patient and provider related barriers which actually prevent widespread uptake and access to these interventions. So computer-based virtual counselor delivered brief alcohol interventions are some of these interventions which may overcome some of these barriers among people with unhealthy alcohol use, and they are cost effective. They can reach to a large number of people with unhealthy alcohol use and can be delivered with the fidelity and provide confidentiality and convenience. So these computer-based interventions are actually largely developed and tested in developed countries and not in resource-limited settings. And for CBIs to be scalable and have a community-wide impact in resource-limited settings, it is important to adapt them to the country-specific cultural context. So with this background, we have conducted this study and assessed if a computer-based intervention which is delivered by a virtual counselor is acceptable and feasible in TB and HIV clinical settings in Pune. Let me briefly tell you about the intervention we used in this study. So the virtual counselor is a 3D character, which is named as PD, the parrot. And using motivational interviewing style, this counselor interacts with the participants to provide information, motivation, and behavioral skills that foster alcohol use reduction or abstinence. And although PD is an avian character, it appears anthropomorphic through its animations like eye gaze and facial expressions and body movements, as well as script, like it gives reflections to the user's answers. And it has over 50 specific animated actions that can be selected to engage interest of the participants, connection, and motivation among them. So actually, this intervention is tested among people with HIV who are hazardous drinkers in the US. This has like 3 domains for the intervention, which has the information which provides information on reasons why people drink, consequences of drinking, and triggers for drinking, etc. And under motivation, it engaged the participants by providing motivators to reduce drinking, such as how they can manage their drinking cravings using 3 Ds, which is like delaying alcohol consumption, discussing it with the family, or having a self-talk, and to do something else to avoid drinking. And under the same domain, it also provides information on what good things can happen if they reduce the alcohol or quit alcohol. And lastly, under the domain of behavioral skills, it talks about setting a goal and how to have a change talk to achieve it. So this is just a screenshot of virtual counselor to give you an idea like how it works, where a participant has to choose an option for the trigger for alcohol use. And then if they use, like they drink because being sad or bored or lonely, then next screen appears to, and the talk continues depending on the options they select. So this is about the intervention. So we conducted this pilot qualitative cross-sectional study where we conducted focus group discussions with the healthcare providers of government hospitals, peer educators, and in-depth interviews with the HIV and TB patients with the unhealthy alcohol use. And we did then content analysis and using deductive and inductive coding, and we actually got the feedback mainly on acceptability of virtual counselor and to identify the characteristics of the intervention that needed adaptation, such as content, language, speed, visual designs of the intervention, and to identify the potential barriers and facilitators associated with the computer-based intervention to determine its feasibility in the clinical settings. So some of our findings are about like acceptability of this avatar is that majority of our patients actually, they like the bird speaking to them about alcohol reduction. But our focus group participants, who were mainly healthcare providers and peer educators, reported that human figure would be more effective, and they are also of the opinion that having avatar would keep the information confidential, which is a benefit, but a counselor available to answer any question patients have would be helpful. And this is one of the quote from one of the FGTs. And there were about the adaptability, there were suggestions on adding options for triggers for alcohol use that included like kind of occupation, locality, family background, and to relieve pain and to get rid of family responsibilities were also suggested as triggers for alcohol use to be added in the program, which are currently not there. Then another suggestion was like concept of a standard drink needs more clarity in the Indian context, because this is something which may not be understood as it is used in the current intervention. And participants also suggested that we need to add some local terms. So this study was done in Pune, where locally people drink fuga, what they call is or a tadi. So to contextualize the content, they suggested that we need to add local drinks. Our focus group participants also of the opinion that it is important to provide information on HIV and TB drug interaction with alcohol and its impact on treatment outcome, which is very important for this group of patients or people. So, and some additional motivators suggested were like talking about impact of alcohol use on liver and kidney, and to develop some cognitive behavioral skills for change in alcohol behavior. They also suggested engaging patients in religious and spiritual events. Regarding feasibility, they found that computer-based and avatar-delivered intervention is easy to operate. And they also said that advantage of the app is it provides a uniform information without any bias that may occur with in-person counselor. But healthcare providers reported that increased provider workload, if they need to be present for an individual patient, is something which maybe like, creates some kind of challenge. And low literacy is one thing which is pointed out, because some patients may not know how to read those options and where to click. So it was suggested that if we put some graphics, that would be helpful. So some of the recommendations and suggestions made by participants were that additional interaction with the human counselor would enhance the program. And the sound of the parrot or the PD was little low. So a loud sound and a slow speed is important. And then the content in local language would be helpful, because at present this app is in English and the PD talks in English. So we had to actually translate the whole script into a local language in Marathi, and then explained it to the participants. And another suggestion was that intervention would be more acceptable if options given are explained with the illustrations, especially to non-literates, as I said earlier, and like showing a happy family or TB patients who have good adherence to treatment as a positive outcome of quitting alcohol. So in conclusion, the computer-based virtual delivered alcohol reduction intervention for people living with HIV or TB is found to be acceptable, and it can be adapted with cultural tailoring, and it appears feasible in Indian clinical settings, particularly if coupled with in-person counseling. Thank you. I will end my talk here.
Thank you very much, Nishi. And I just wanted to thank actually all of the panelists for these excellent presentations, ranging from the extent and magnitude of substance use in India to very under-researched areas, as well as trying to understand the scope for adolescent substance use prevention and treatment. What I also noticed that make your programs distinct is the heavy reliance on user-centric design and participatory work, both of which are very essential for successful services and research outcomes. So I'd first like to start off with a question that I'd like to ask to all of the panelists, so that everyone has enough time to type in their questions in the chat box. Just again, an encouragement, please leave in any questions that you may have in the chat box, and preferably actually in the Q&A tab that you'll see on your screen. And we'll of course come to that very soon. So a question that I'd like to pose to all of you is, if you could address two interrelated questions about what are some barriers and facilitators that are unique to India that your work has been affected by, and how did you leverage or overcome them? So anyone would like to go in first?
May I?
Yes, Atul, go on. Yeah.
Yes, thank you. So there are quite a few barriers, in fact, in India when we talk about trying to conduct epidemiological research. One first barrier is that who is the main stakeholder in this process? unless that main stakeholder is actually willing to support and have a commitment that they will at least accept whatever your results produce. It's a area which is difficult to venture into, because we have seen instances in the past where researchers have conducted epidemiological work, but officially the results, since the power of the day didn't like the results were not readily accepted, or they were contested heavily. And not just in substance use or mental health epidemiology, in other areas we see around us. If we are watching news and reading news, we know there is always a contest between the numbers produced by the independent researchers and the government on various fronts. So that's a sensitive line to trade actually on, where you gain the confidence of the research community, applying the right ethical research principles as well, maintaining the stringency in the design, and yet keeping the governments also sort of happy and engaged with your work. So that has been one of the challenges, and for which uh, uh, appearing a very non-partisan, appearing very neutral and non-interested party in either kind of research findings is very, very important when you venture into these kind of research. So the governments which actually engage you, they must they must get this very clear message that you as a researcher, your health is not going to be affected whatever numbers are thrown up with this research. So then you are actually seen as a non-vested interest party, and then you gain some trust. Also, when you are content with showing that uh, that, that 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 the research and having the research outcome in the public domain, and you being identified as the researchers, is the incentive enough for us as academicians, and not really the findings of the research, that also enhances the some degree of confidence with the government. Also, it's very important that we often understand the importance of involving the local communities for whom the research is being conducted, and I totally agree with this. We always try to do this in our work, but along with local communities, there are other opinion leaders and other important stakeholders in the areas, including the local administration. So keeping them also informed and engaged becomes very important. So one issue is, and very often these two people are actually at the loggerheads. Very often what we call as local community, which means in our case, people who use drugs, and local administration, which means police, they're actually after each other. They are enemies of each other. So keeping both of them engaged and happy, and being assuring that their confidentiality, etc., will be maintained, that can become tricky at times. So that's something which we thought is a challenge, and can at times produce some difficulties. I will just conclude here with one last challenge which we observe in the epidemiological kind of research, is that who should actually collect the data. Involve local community, which means should we have local people conducting the data collection in the local language? Sounds very good and appeals to actually logic also, right? But then too local a person also sometimes can backfire, because too local a person then is known to people, and that with a known person disclosing your substance use, your other illegal behaviors, can be a challenge. So someone which you can see as a neutral person, it won't matter to that person. He won't judge, he or she won't judge you for whatever you are doing, also becomes very important, rather than apart from being comfortable in the local language and culture also. So these are some of the thin lines which we need to sort of balance while planning and conducting this kind of research. So that's it for now from my side. Thank you.
Yeah,
Thanks, Thanks, Atul,
Sorry.
for that well-rounded response. Sorry, Nishi, please go ahead.
Sorry, no, I completely agree with Dr. Ambekar what he said, but in for our setting, like we usually like mainly work with HIV and TB patients, so we need to involve the stakeholder, the program stakeholder, the program implementers, and we explain and tell them what we are going to do. So it is much easier than to bridge that gap between the program implementers and the patients, and it is much easier as they believe more than researcher to the program implementers who from where they are taking the medications. So it's a kind of what you say that we sensitize the program implementers and as well as community stakeholders. Like we have a community advisory board where we present our studies, research studies, and then we get their inputs. Like because as you know, these are the sensitive topics, like to talk about mental health or to talk about substance use going into the community. So that is one area where we get a lot of help from the community as well as from the program implementers.
Thanks, Nishi. I'll just allow Shilpa to make any comments before we go on to a few more questions.
Yes. It was really interesting to hear the on-field experience of Atul sir and also Nishi ma'am. I would like to give my experience and Mukti's experience. Since I am coming from I am a student, I'm a postgraduate student, and I'm surrounded by students. I feel like research being facilitated among students is very much needed in today's day and age. In that sense, we need to encourage not just postgraduate students. As postgraduate students, we are asked to do our thesis, which is mandatory, but even undergraduate students, which can help in having a better thesis while we are doing post-graduation, because what I have noticed is my personal experience, because I had some sort of experience when I was an undergraduate student. I was able to do my work more efficiently with much more ease, and I was able to handle my work and my research side by side, in addition to dealing with other things. But I feel like even though things are made mandatory in our curriculum, we are not made aware of how to go about with it. Like, for example, how to approach patients or how to approach people, and even the basic things like, we need to capacity building in the sense of providing basic skills. For example, even Excel or Word, and even citation management, basic things we need to encourage and facilitate at a central level or at a government level. So students like us, we are more happier and more, it'll easier for us or for everyone to do research. And it should be done in an ethical way, and there should be quality research, and that's more important. Yeah, so I think that's one thing I would like to say, which I have noticed. And for Mukti particularly, I think this is very important because we are dealing with such a sensitive topic of substance use, and because we were students, we faced a lot of issues when we were approaching people for mentoring, and for people when the idea came up, and also when we were doing the research. It's very difficult. I definitely understand that there are certain aspects associated with it, and it was the right thing to do. But at the same time, even though when we had everything ready, we had the facts and we had all the paperwork ready, we were still facing issues because it was very difficult to get that acceptance, and from maybe ethics also, or even getting that acceptance in the society. So some challenges, and apart from ethics, I think one thing that I've noticed, I don't know, maybe you all can add, is that if we're doing like there's an ethics committee in an institution, and when we have students from all around India, and we want to collaborate, and we want to give everyone a fair chance, whoever is contributing, and we want to involve principal investigators from different places, but we are not sure which ethics to go, and there's so much of money involved in even applying. And when we are working for a free of cost, we're working as an initiative, we are limited in those resources. So we had to really struggle in terms of getting those approvals, and we're still struggling. And yes, so I hope that there's a more streamlined process to make approval and research more easier for students.
Thanks, Shilpa. I think these are very relatable challenges and barriers that you've highlighted. And also just wanted to thank also Nishi and Atul, very interesting solutions that all of you have raised in relation to your work, and particularly highlighting how we must consider who is one researching, how can the community be involved in research, and how does one incentivize participation? And most importantly, how do the voices of the people that we're working with inform our research design and implementation. So I think there are related questions in relation to your opening comments as well. We'll just directly dive into those. I'll go on to the first one that I see on my screen. This is for Dr. Atul. Since you mentioned that engaging with government or policymakers is a challenge, what are some strategies that we can use to engage with policymakers and politicians?
Yeah,
So first, Dr. Atul, and if Shilpa and Nishi, feel free to also add in.
right. Right. So one is that engaging with when I say engaging with policymakers, I mainly understand in terms of bureaucrats, not so much politicians. So involving and confiding in taking confidence of the political leadership is very important. But researchers directly doing it with politicians, I'm not very comfortable with that idea, right? For very obvious reasons, because the politicians change, and if you are actually taken confidence of one set of politicians, another set who replaces them actually will see you as a not a neutral person. So what's important is that convincing the bureaucracy, the senior officials in the government, and to convince them actually, that may take a lot of time and efforts, and also which will also be based upon the credibility which you may have based upon your own or your associates own previous work. So associating yourself with people who have done credible work in the past, if you are new to the field, or your own work, based upon that, convincing them the importance of undertaking this work and moving ahead with this, even if in the slow and sustained manner, and will very important. And while there are some basic non-negotiable principles for all of us as professionals, please also be flexible to negotiate. You ask for whatever you ask for may not be already be granted. So I'm not just talking about resources, I'm even talking about the scope of your research as well. I'm even talking about some of the way in which you conduct your research as well. So if you're seen as person who can sort of accommodate their concerns as well, the task can become easier. But all said and done, there is no fixed formula there is no fixed template which will always work. It's very often a trial and error kind of job. And like politicians change, the bureaucrats also change. You cultivate your relationship and the rapport with one person, and by the time there is opportunity to sign those important papers, the person gets transferred and replaced by someone else. Then you start from the scratch once again. So it can be challenging at times, but being honest to your job, and sort of basing your arguments upon your own credible work in the past is something which can help.
Thank you, Atul. In fact, there is a related question, and if you could just let me know if you'd like to add anything about that, or whether your answer would suffice for that as well. So the question is, despite the glaring evidence related to the huge burden of alcohol use, the interest from both policymakers and funders is missing. How can we change that?
Yeah, there's something I'm also grappling with, but the simple answer to the one simple answer to this question is that alcohol is a state subject in India's federal policy system of polity. So a national consensus it's very difficult to emerge around how to regulate or how to go about discussing alcohol. And that's where most of the discussion gets stalled. Without the stakeholders in the central government also not realizing that alcohol is a state subject, regulating the taxation, etc., may be left to the state governments. But a public health issue, it's a general population issue for the entire country. So some broad alcohol demand reduction as well as health related interventions is something which will work across states, whether whatever the state's policy regarding alcohol is. So that realization is very, very difficult. And also in terms of the I suppose in terms of the glamour associated with working on a particular issue, there is much more sensationalism in talking about drugs as opposed to talking about alcohol. So even use of a substance like ganja once creates much more sensation than someone drinking their liver out. Right? So it's not the amount of health damage, but the importance which also depends upon the kind of way it is a substance is pursued and portrayed in our general discourse. So I also totally agree that the illicit drugs, they tend to get much more disproportionate amount of attention as opposed to alcohol, which has much higher public health burden. And for both alcohol and tobacco, in fact, tobacco is also the similar story. Unfortunately, for both alcohol and tobacco, whenever the talk of health effect or how to deal with it goes, the first response is about how to control the supply or how to increase the awareness, which means the large size hoarding or how big should be the warning on the packet and so on. So actual working with the people who consume these substances and are affected by them, how can we help them? That kind of research interest has been lacking. So this is something I totally echo the concerns raised by our colleagues here. I don't have definite answers.
I'd
Thanks,
like
Atul. Yes, Shilpa, yes.
Sorry, hi. Yes, if Nishi ma'am does not have anything to say, I would like to add something to what Atul sir said.
Please go ahead, Shilpa. Yeah.
Thank you, ma'am. So what I think about this question is like about how do you interest both policymakers and fundraisers is missing, and how do we change that? I think like one most important aspect that I mean what MUKTI was able to do is to create that awareness, and we have enough information, but it is not reaching to the public. We have information in our research journals, but it's not reaching to the public. And that was what MUKTI was able to do. We made posters, we created psychoeducation, and we were able to put out facts that would say that, okay, this is what it is and this is how it leads. I'm sure there is already there, but it needs to go, the magnitude of it needs to increase, because the awareness among the public is very less. And also, I would say there were some recent events that have happened in the state of Maharashtra, which also suggest that the awareness among policymakers is also less. So I am trying, what I also think is, one is psychoeducation, and the other thing is we need to, so I think that, so psychoeducation would be one of the main things. Yes. Yeah. And also, I mean, okay, so now coming back to this, there was also evidence that restrictions on alcohol use is very, is useful. WHO has released the strategy where it says that, yes, restrictions on sale, restrictions on timings, restrictions on certain things can reduce, definitely advertising can reduce. But, there's this big, I think there's this big sort of debatable topic that runs in our country also, is about banning alcohol in certain states. And I feel like we don't have a definite answer to it. But at the same time, we have certain people who constantly say that it is okay. It's okay, and banning is the wrong way to do it. But why don't we think of the other side? Has legalizing it made the situation any better? So I think that we need research to also look at this, because banning is at a state level, and it's such a big covering huge masses, how has it made impact? We need objective data and objective research. Just to give you an example of a village in Maharashtra, in Ahmednagar, which was successfully able to ban alcohol, and you could see the people, like what Atul sir said, people are wanting it, but there are certain people who are contradicting the needs, and because of which we see that there's a lot of progress in terms of like the poverty has improved, and also the population become more progressive, and also about the recent episodes of the ban in Bihar. There's a lot of contradiction. Local people are saying that they are benefited, but we're not, and we're not able to find the absolute numbers. We're not able to find the research suggesting the benefit or even the harm, like it has not benefited. So there is nothing out there. So I mean, I feel like even research in certain aspects like this is missing in order to make the policymakers change their decision. Yes, thank you.
Thanks, Shilpa. Nishi, I think you were trying to say something.
No, I just want to say, like whatever Shilpa has said, and there it is a complicated kind of phenomena, and there is a lot of hidden things that happens. Like even if it is a state matter, and there are a lot of even if there is a ban or there is it doesn't mean that you can stop the alcohol consumption. It is like we need to, the research is definitely important, but what I want to say is that it is not as simple, because this is something like which is stigmatized, which is, and alcohol use is very much underreported. Like maybe Dr. Ambekar able to say that like he already told that if you go to the household and ask and people are not coming up, like even when we see in the clinics, they get their drugs and then you talk to them, we have to spend at least 15 minutes talking to them about a lot of other things, develop that rapport, and then, say that still we feel that, it is lot of people don't accept that they are consuming alcohol. And another thing I would like to say is like policymakers and how to change their mind or how to engage them. It is very important to disseminate the result of your studies. And it is not a one-time phenomena. From the beginning, they need to be engaged. And you keep on, it's an ongoing process until your research study is over and you come up with the results. You have to engage them throughout the study so that for them to understand the importance and what kind of implication it will have nationally or at the state level, or then it would be helpful in implementing and to scalable kind of, program in the country. So just wanted to add that, yes, it is difficult, but yes, we need to do more research and engage the policymaker more, I think, intensively in these things. Yeah, thank you.
Thank you. Thank you, Dr. Nishi and Dr. Shilpi. I think there's unanimous agreement that it is a tricky, complicated, challenging area to work with when we talk about the interface between research and policy and funding. But there are very important and useful solutions that you have highlighted in your responses. For example, ensuring that there is timely adoption as well as dissemination of evidence that is generated through programs. I'll go on to one more question that has been posed by the audience. This is for Dr. Shilpa, before perhaps there's more time for more questions from me. The question is, what is the response of other stakeholders, for example, seniors and parents, to campaign for young people? What do you think about intervening with them so that they can better support young people who are struggling with addictions? So first, Dr. Shilpa, and then we'll go on to Dr. Nishi and Dr. Atul if they'd like to respond.
Okay, thank you for the question. And I think that's a good question. So definitely we have stepped out of the norm of only focusing healthcare or providing mental health services through specialized healthcare practitioners, that is psychiatrists or trained psychologists, but we are facilitating medical students to do that. Now, is it possible for family and seniors to do it? I think that definitely giving the awareness and spreading the awareness can help it. And definitely, but I think more than family members and more than seniors, I think important primary level people who are involving with the public, such as police personnel, teachers, and community workers, I think definitely they can make a bigger impact because they deal with such situations and come across more large number of people. So I think that definitely parents and seniors in terms of giving awareness, but more in terms of the other service providers in creating this empathy towards mental health and the people who are having, who are suffering with substance use disorder, and to understand it's a social problem and not just, it's not that he is responsible for it. So I think that's necessary. Yes.
Thanks, Dr. Shilpa. Nishi, Atul, would you like to add anything?
I don't have anything to add to it, but if you allow me, I will ask a very brief question to Shilpa. Shilpa, I was I'm very impressed with with your presentation today. And earlier also, I have come through the work of MUKTI, and which has been very interesting, very encouraging, very inspiring. I just have a small doubt that student population. I understand that this is by and large student-led and student-centered work, which you guys are doing, right? But by and large, as we understand, students are a floating population. They come and then they go. So how do we propose to sustain the interest of all the students which are incoming through the years in the to keep it at the same level, and in fact scale it up?
Thank you, sir. And sir, yes, it's an important question. And sir, what we have understood with our experience while dealing with students is that it's, one thing that we found difficult is to keep the enthusiasm ongoing, because we are such a large student, and everyone has work commitments, study commitments, and we are in a medical field where it is quite challenging also. So what we have, but because we are dealing with largely we are dealing with medical students, we realize that they might not necessarily be with us at here, but they will continue to be providers for mental health through these counseling sessions in their day-to-day life. And what we have noticed, even when we practice, when we go to rural areas and when we are working in a PHC, is even though we have the district mental health program implemented, but people are reluctant. We feel that we feel that the healthcare providers are reluctant, and they're not confident to treat, so I think that this doing this through MUKTI, we will help change that scenario. And if this is administered to all medical students, I think it will be easier for even if they step out, it will be easier for people to accept and deal with certain situations, even otherwise. Yes.
Thank you.
Thanks for the question, Dr. Atul. With that, I think if I could just remind everyone, if you have any question, please leave it in the Q&A tab. I'll perhaps end with one question in the interest of time. If each of you could reflect on any opportunities that you see for research, particularly in your area of work in the coming 5 to 10 years.
So I can go ahead with what I feel about my research is, like, as I said, that this was our pilot study, and this program can evolve and include the adaptation to incorporate the recommendations that were given during the pilot study. And I would be interested to examine whether this program is feasible and accessible in different parts of India to assess its generalizability. and to also assess the cost effectiveness of computer-based intervention. I'm saying that because I think India is the largest Android phone users after China. And if this kind of app can be developed and we assess its acceptability among the patients and in general also, like among those who are having unhealthy alcohol use, and see that, so for that we are planning to have a plan a study which could be a randomized controlled trial, and which can be implemented in different parts of either Maharashtra state we are going to start with, and then maybe in India, so that this can be this can give us a much better results in a bigger population, and can be adapted and scaled up to other regions of India too. So that is what in future our plan is to write a bigger grant using this computer-based intervention.
Right. And Dr. Nishi, if our audience wanted to get in touch with you, how would you recommend they get in touch, and also where could they follow your work from?
Okay, so my email address, should I share it on the chat box? In the
yes,
chat
that'd be
box?
helpful.
Yeah. Okay, I'll just share it.
Thanks, Dr. Nishi. Dr. Atul?
Yeah, I mean, one is that the epidemiological surveys on different aspects of substance use, they are likely to continue now. The recent national survey and the reaction to it has actually highlighted, and the kind of issues which Shilpa was highlighting, that we need to have impact, the differential impact of differential policies need to be properly assessed. And these are the kind of questions many people, including in the stakeholders, are raising, including politicians are also raising these questions, that fine, if you have prohibited, show us the impact, and so on. So that kind of work is likely to continue, and people working in this particular area can look forward to many such opportunities in the future, at the local level, at the national level, at various levels. What I want to actually say is that I have a wish list, a dream kind of research which must take place, is a young people led research on use of different kinds of psychoactive substances, particularly the newer varieties of psychoactive substances which are being used by the young people. We the mental health provider community actually tend to see the worst aspects of substance use and their worst consequences. When people develop addiction and they actually need help, that's when we see them. But there is a substantial number of people who are using substances, and at this moment they are just enjoying it. At this moment, at least, they are not really have gone into the level of developing addiction or other harmful consequences. And these people can be a very potentially very good source of information. Unfortunately, they are always seen with a lens of doing a wrong behavior, indulging in an undesirable behavior. So globally, there is a group of people who work on something known as global drug survey. So something on the similar lines, I believe, if Indian young people can take up this challenge and can start online, anonymous, but truthful sharing of experiences, sharing of information on the substances which are used, which are likely to be used, what are the consequences. I'm highlighting young people here is because that will herald actually the new waves of patterns of substance use. If new substances are being entered into the market, if the young people are likely to try them, if there are some new consequences which are happening, then young people can tell us about them. So if such kind of forum is established, where we, the researchers, as well as the policymakers, in a non-judgmental way, can learn about what's happening in this world of people who use substances, that would be great. So I don't know what shape or form it will take, but something of this sort must take place, and but should be led by young people only, led by the community of users only, not by any of us gray-haired people.
All right, I guess that disqualifies me as well in that case. But thanks, Dr. Atul. I think that's an interesting recommendation, both focusing on user-centric research as well as focusing on use of substances instead of misuse and the more serious end of the spectrum when you talk about addiction. All right, we'll go on to Dr. Shilpi. Any last thoughts about next steps in your area of work over the next 5 years?
Yes, so I think that we're like Atul sir has given us his amazing research work in terms of the magnitude of substance use in India. But also, I think we need to, like we earlier said about, talking about assessing the impact of the implementation of policies, but also working on ways to the preventive models to assess if the preventive models are working and how. So that is one of the principal aspects that at the moment we at Mukti are trying to do, because we have a lot of content that's going through social media, but we're not able to assess how many of these people are getting called, are the callers for us, and how many of them are getting motivated because of this education, and or what particular post that they have seen that is leading them. So we are trying to find a way to do that, and that would be very important. And I think Atul sir's suggestion is a very good motivation for us also, because we are interacting with the users as well through our helpline, and we are able to I feel like our users are all young, and I think they can relate to Mukti, the way we put out the information. They like I mean, there's something, because there are other callers and there are other helplines also which are more authentic. Like, we say that we are medical students. So despite that, till now we have received about 45 calls and callers, and each caller has called several times, of course. And so that's the thing, and I think we can definitely think of it in the future, of how we can put the information that we get out on a platform where it can help in important decision makings in the future. So coming about research, I think applied research, participatory research, which involves the people knowing the problems and then implementing the change. And also there has been a lot of, we have understood, I think even yoga as known to help in improving craving management. So we need to think of this and get objective research in order to understand how it can exactly help. And so mainly focusing on preventive models more than, we are right now focusing on the cadre of treatment in a situation of substance use where it's an addictive substance. Where you have other health problems, prevention is always better. But even in substance, where it is such an important thing, where it causes an addiction in an individual, prevention is always better. So I think that we also, there's a lot of lobbying that happens in the other side, where they try to facilitate changing policies in their direction. I think we also need to do that. We need to build and make our presence be felt, because we just become passive, and because of that, it's just accepted. But it was really interesting to see the recent event that has taken place in Maharashtra, where now the opinion of selling wine in shops has been put up in the public domain, and it's been asked for people to respond, and that's very important. So taking people's opinion, and it's our time to act, and we need to respond, instead of just hiding back our opinions. But also very important, many of people who will respond are not aware. They are always driven by their social interests or what they like. But so taking an informed decision in this matter is also important. Yes, thank you.
Thanks, Dr. Shilpa. And I also just wanted to comment about the fact that your work is really inspiring as a young researcher yourself, and then very important messages that you are emphasizing and reiterating as well about prevention, about focusing on use, etc. There's one last question that's come from the audience. I'm going to read it out, and if one of you would like to take it on. So here it goes. I thought I registered one of the speakers advocating for alcohol abolition policies, citing anecdotal evidence of its effectiveness. I'm wondering if the panel can clarify. Okay, the question has disappeared.
may I quickly sort of respond to it?
Yes.
I
I guess they just wanted you to clarify the stance and
yeah,
what
yeah,
what are effective approaches.
yeah. I think it stemmed from what Dr. Shilpa was suggesting about Bihar example. I do not think that this panel's take-home message is that alcohol should be prohibited everywhere. Let's make this very clear. Dr. Shilpa was merely suggesting that if some states have practiced prohibition, implemented prohibition, let us have research documenting its pros and cons. What are the likely good effects? What are the not so good effects? And let this come out in public domain so that everyone, including the other states, can learn from it. And that should be the take-home response, that all policy measures should be judged by not by their intention, but by their outcome. And outcome as assessed as broadly as possible, not in very narrow terms of how many people admitting use and how many people admitting abstinence. So I think that should settle the debate without going further into it.
Yes, thanks, Dr. Atul. And I think it is definitely a webinar and a panel discussion in itself. It's unfortunate that we have only 4 minutes left, but thanks for addressing that point. So I think with that, we would close this webinar. I just wanted to emphasize that though we have yet to go, there's a long way to go in terms of effective implementation of interventions for alcohol, drug, and tobacco-related problems. The ideas that all of you put forward today, so for example, the avatar-based alcohol reduction program, the program that Shilpa talked about with prevention in young people, should reassure us that we are in a position with abundant opportunities and choices to make. And the success of these programs will entirely depend on how closely we listen into our communities and work with each other. I've also learned that the future calls for strengthening of the evidence base, both for substance use as well as misuse, both in India as well as generally around the world too, that we come together and implement programs across sectors, and that we also very strongly focus and emphasize on evaluating and developing rigorously evidence-based and innovative approaches to addictions. With that, I'd like to close today's session. Today is the last session. This session is the last session of our Sangath 25-year webinar series. Although we have joined in today to commemorate Sangath's 25 years, I'd like to take the opportunity to appreciate the unwavering efforts of our panelists here, who have ensured that addiction is at the fore of the national discourse. You may view our previous webinars on YouTube. We will add the link in the chat box in a few seconds. And I would just like to thank the panelists as well as all the attendees to listen in. And I hope that you enjoyed our webinar so far. Thank you.
Thank you.
Thank you.
Thank you.